Hello, future PTAs. I hope that you all are doing great. So, today we're going to talk about UV therapy, ultraviolet. So, this is our outline. Ultraviolet is a type of electromagnetic radiation, but it has a very specific parameter. So, the frequency is 7.5 times 10 to the 14th or 10 to the 15th hertz. So, a whole lot of hertz, whole lot of zeros. The wavelength can go from, I'm sorry. All right. Hopefully that's my last yawn. Probably making you yawn too. The wavelength can go from below 290 nanometers to above 400. The different types of UV have different wavelength. The wavelength. The longer the wavelength, the lower frequency and the deeper penetration. So remember that the longer the wavelength, the lower the frequency, the deeper penetration. And the wavelength is between X-rays. Some of the factors that affect the intensity of UV reaching the patient. So it's an inverse square of the distance of the lamp from the patient. So the closer, the higher intensity. Power output from the lamp, and then the cosine of the angle of incidence of the beam with the tissue. So we're going back to former math classes that you may have forgotten, but you don't have to remember and figure out the cosine. Just know that in order to get the highest intensity, you would want to use a high-powered lamp, get close to the patient, and have the lamp perpendicular to the patient's skin. So closer, higher power, and perpendicular to the skin are the highest intensities. Some of the effects: erythema, which is that red coloring of the skin; tanning; epidermal hyperplasia; vitamin D synthesis; and bactericidal effects. So back to that. So it kills bacteria, it helps you make your vitamin D, and then the others aren't necessarily desired effects. They're just some of the effects they have, but they do help us decide dosage and how much is safe for a patient. So the erythema production that is primarily from UVA and B, and kind of tells you how sensitive the patient is to that type of UV. With vitamin D, the UV irradiation of the skin is necessary to convert provitamin D to active vitamin D. This can also be ingested through diet or through supplement. Vitamin D is broken down in the liver and in the kidneys, and it increases your calcium and phosphorus absorption in the intestines. Vitamin D helps mobilize calcium to help it store in the bones. So even just taking a walk outside with some of your skin exposed can help absorb vitamin D, or of course eating foods that have it in there, but it is very important for a lot of functions in your body. Some of the indications, so psoriasis is one of the primary ways that UV is used currently, the most common way. So it's most responsive to UVA and psoralen, which is abbreviated PUVA. So you put them together. So psoralen you can put on topically and ingest, take through like a pill form to help with the effectiveness of the UV on psoriasis. So narrowband UVB is almost as effective as that combination, and it's safer. So they believe that the way that this works is it inactivates cell division to stop the proliferation of the epidermal cells, because psoriasis is a buildup of dead skin cells. It inhibits DNA synthesis, inhibits mitosis of the hyperproliferating epidermal cells. So they're going into overdrive, they're creating too many, and it's stopping that process. It could be used for other skin conditions as well. With wound healing, UVC is the most common one used. And one of the reasons is it doesn't cause the erythema or the tanning. One of the mechanisms, so we believe that it increases epithelial cell turnover, it accelerates granulation tissue formation, it decreases the bacteria, and it promotes sloughing of the dead tissues. And then the research to support this is limited, so it's really unclear how much it affects wound healing, but it has been used in the past for that reason. Some of the contraindications, of course, you'll have to know these in the precautions. So you do not use UV over the eyes, just like with EMR. Do not use it directly over the genitals or in patients who have skin cancer, pulmonary disease, cardiac, kidney, or liver disease, systemic lupus, fever, or a recent x-ray. Precautions if they are sensitive to light or on medications or supplements that make them more sensitive to the light. If they have recurring oral herpes virus infections, um, and you do not repeat a UV treatment until the effects of the previous dose have completely disappeared. So if there's any redness left, you wait until that disappears before you do it again. Some of the adverse effects that could cause a burn. You want to assess the minimal erythemal dose, which we'll talk about later, prior to starting a treatment. It could cause premature aging of the skin. That actinic damage is what's pictured in the picture of the hand there. It could cause cancer and it could cause eye damage. So, how do we determine the MED, which stands for minimal erythemal dose? So, first you put goggles on to protect your eyes and the patient's eyes. Then you expose the skin that's going to be tested, but cover all the other skin. And you place a piece of cardboard with 4 holes in it over the test area. You place a UV lamp between 60 and 80 centimeters from the test area and record exactly how far away it was. And then you start the treatment. You turn on the UV lamp and all holes are uncovered. And then you cover up the holes after certain durations. So the first one you cover up after 120 seconds, and then 60 seconds later you cover the next, and then another 30 seconds you cover one, and finally after another 30 seconds you just turn the lamp off and you observe how their skin reacts to that over a 4-day period. So the I forget the word, minimal erythemal dose is the dose that is the smallest dose that produces that erythema within 8 hours, but that erythema effect goes away within 24. So whichever dose, the smallest one that caused that erythema effect to occur within the 8 hours, but then to go away, that is what you will be using. What do you do when you use this with a patient? Once you've figured out that minimal dose, you, of course, determine if it's safe and appropriate before you even do that part. But you warm up the lamp, you put your goggles on, you expose the area that's to be treated and cover all other skin that's exposed. You position the patient and the lamp at the appropriate distance and appropriate angles. You remember you want the lamp perpendicular to the patient's skin. Then you turn the machine on. Then you observe the treatment area and document their response and all the parameters. When you're selecting a lamp, there's two different types of lamps. The arc lamp is pretty small and emits radiation in a consistent intensity. The fluorescent lamp is longer. It emits higher radiation in the middle, so you have to be careful with that. And then lamps should be cleaned regularly. You want to be careful with how you store and clean the lamps. For documentation, you will want to write um, if you gave that Suralin, if they took it, when they took it, what area of the body you treated, the type of radiation you used. You want to document the lamp serial number because different lamps may have different um, intensities and how recent the bulb was changed and different things. Distance of the lamp from the patient, the treatment duration, and the response to the intervention. All right, that is everything for us for UV, and I will see you in the next lecture.